I'm really excited to introduce our speaker. We have Alaina Tellson here, and oops, I've got to put my glasses on. She got her PhD from the University of Texas at Arlington. She's currently the Director of Professional Practice at the Heart Hospital Baylor-Plano and the Heart Hospital Baylor-Denton. She oversees the Skin Champion program developed in 2011 that addresses the prevention of hospital-acquired pressure ulcers. During the first year of the program, the hospital had an 80% decrease in HAPUs. That's amazing, and has continued to maintain it, which is even more amazing. So please help me welcome Alaina.
Maybe? No? Okay. I was getting all these blank stares in the room. How many of you guys know what a happy is? About half of you? Okay, good, because we're going to talk about that a little bit. This will be great. So today we're going to talk about saying no to happy. We're going to bust through some walls and talk about how we overcame our challenges and our barriers at our facility and in our healthcare system. So what is a happy? The National Pressure Ulcer Advisory Panel came out with this new definition of a HAPU a couple of years ago. So how many of you guys know what a HAPU is? Okay, so they went from ulcer to injury a couple of years ago. And so we've been saying we're not happy about happy, and so we don't want you guys to be happy about happies. Okay, there's nothing happy about it. So a happy is a localized injury to the skin and or the underlying tissue, usually over a bony prominence. It can happen in other places, but that's where it usually is, as a result of pressure or pressure in combination with shear and or friction, so from like your bed sheets and things like that. What I don't want you guys to get today is SAPI. Any of you heard of a SAPI? One of you's heard of a SAPI. A SAPI is a summit-acquired pressure injury. So, or at our hospital, the Heart Hospital Baylor-Plano, we have no APIs, a term that my wound care nurse out there in the distance coined, and that is nursing orientation-associated pressure injuries. Okay, so we want to make sure if you need to get up and get off your bony prominence that you do that today for me. Okay, so let's talk about why we're not happy about that. Well, HAPIs affect more than 1 million patients per year. It's a staggering number for us. This number was from 2014. We're still looking for some updated numbers. It's still saying about 1 million, but can you imagine 1 million people having anything else happen to them and that be acceptable? The treatment costs can range anywhere from $1,200 to $70,000, depending on the stage of the pressure injury or ulcer. And it's costing the United States healthcare $11 billion. Now, I don't know about you, but I could do a lot with $11 billion at my hospital. So we want to make sure that we get that money and get it out of penalties. So why do we need to say no? CMS has come out with some statements about HAPIs or HAPUs. So I'm going to use the term interchangeably, and please forgive me. The nursing side of the world has taken on the HAPI, but CMS is still talking HAPU. So they haven't changed the medical coding for these as of yet. So we want to make sure that you guys understand that it's the same term. So CMS does not reimburse us when we cause a pressure injury. Were you guys aware of that? Okay. So this is costing your hospitals money. A stage 3 and 4 have been identified as preventable by CMS. So you guys remember earlier when Leah was talking about the never events? This is one of those never events, okay? Let's make sure here. In October of 2016, CMS also came out with new coding and rules. So present on admission pressure ulcers. So those pressure ulcers that are already there when the patient comes in, you guys document those. We used to be safe at that point, right? It was already there, we didn't cause it. But do you know now if the stage progresses, that it is counted against us as a hospital acquired? So we have to keep it at the stage that it's at, or hopefully help it heal. And then research shows that strong collaboration and a strong collaborative approach can help reduce the number of happies in our organizations. So let's talk a little bit about staging. How many of you guys stage wounds in here? I figured it's just a handful, right? So we're looking at identification. That's why staging is important. What stage are we at? Treatment options are typically based on the stage of the wound. Prevention of the progression, we typically also need to know the stage we're at now. And then care team communication. It helps us collaborate and talk the same thing amongst each other. How many of you guys have problems with staging at your facilities and the bedside nurses understanding staging? Anybody? Yeah, a lot more hands there. How many of you guys are still allowing nurses to stage, or do you have somebody that comes in stages? Somebody that comes in stages. Good. Okay. So these are the 6 different pressure ulcer stagings that are recognized out there. The one on your, this doesn't work. So closer to me, this stage 1 at the top, that's a non-blanchable injury. So when you blanch, push down on it, are you getting that redness back or not? Okay, that's a stage 1. Stage 2 is the one next to it, and that's a partial thickness. So you see how it's kind of starting to go through the epidermis and get underneath. A stage 3, now we're starting to get into full thickness here. We're getting some involvement in the layers further down, but we're not quite to the bone or the tendon underneath quite yet. Then your stage 4 on the bottom, you see we're getting down to the bone and the tendon. And so when we get down to that bone and tendon, what else are we worried about now? Some osteomyelitis, some other things starting to happen to our patient. In the middle is the one that we just love at our hospital, the deep tissue injury. Okay, that kind of appears like bruising to most of our nurses, and they're not sure what to call it. We even had a nurse call one day and tell us that their patient had little purple dots on him, and we went and educated to the difference between a bruise and a deep tissue injury and skin markings from the OR. Then on the other side at the bottom for you is unstageable. And unstageable pressure ulcers, we can't tell, right? You guys see there's a lot of eschar on there. So at that very top, that's all we're seeing. We don't know how deep this is going. And unstageable pressure ulcers are the ones that we really like to stay away from. Okay. So usually pressure ulcers take place over our bony prominences. So a little bit of anatomy. You have the occiput, so the back of the head, and a lot of people don't think about that, right? They think, oh, my patient's laying there, they got a pillow, they're fine. They don't think about that pressure that's being caused. The shoulder blades, anywhere along the spine, our elbows, our sacrum, coccyx, and heels. And you can see we have it on the front and the back, so your ankles, your knees, any of those bony prominences. Okay, so one thing that's real important before you start talking about pressure ulcers in your facility is how are you measuring those pressure ulcers? How many of you guys do a monthly prevalence study or a quarterly prevalence study? Okay, so that's the bottom one. So prevalence measures the number of patients with pressure ulcers at a certain point in time. So we like to say that's on that day. Whenever you went and made those skin rounds, that's what's there right now. It doesn't really tell you whether or not you have a problem. If you report to the Indian QI and you're reporting 0 every month, does that mean you really don't have pressure ulcers ever? No, but that's the message that your nurses get. So we moved Baylor Healthcare System to incident density reporting. How many of you guys have ever heard of that? Oh, good, a couple of people. Incident density measures the number of patients developing new pressure ulcers during a period of time. In our healthcare system, that is daily. So we have a report that we can pull from the EHR that tells us if there was a new pressure ulcer documented on any given day. So rather than on that specific day, we can actually look day by day and see what's going on. And we can give our nurses a better number that they can understand than the prevalence study. And that's going to be important when we talk about our hospital's journey. So let me tell you a little bit about our hospital before we get into our journey. We have 2 hospitals. One is located in Plano and one is located in Denton. So this story is about our hospital in Plano. Our hospital in Denton has had 1 pressure ulcer since we opened the doors 3 years ago. 1. And Rhonda's back there going, yes, yay, okay. So just think what we did is we replicated this program out there and have kept all but 1 patient from getting a pressure ulcer. So our hospital in Plano is a 116-bed, freestanding cardiovascular specialty hospital. We have our own ED, our ORs, everything. So all we do at our hospital is cardiovascular care. We have the sickest of the sickest patients in our hospital a lot of times. We have patients ranging from those that just had chest pain and are there to get checked out, get a cath, in and out real quick. And then we have those patients that are on long-term ECMO, laying in our beds for days and days that we wish we could suspend in the air, but we can't. We also have a cardiac universal bed model. So if you're not familiar with the universal bed model, essentially any of our patients can be in any of our beds at any time. Our rooms convert from telemetry to PCU to ICU and CVICU. We match the patient's needs with our nurses' skill set, okay? So keep that in mind as we go through this. When we're talking about this, this includes what you might call in your hospital your CVICU. Those are our patients as well. So these are the numbers from before we started and into 2015. So this was the journey that we went down. We were number 1 in our healthcare system in a very bad way. We had the highest number of reported pressure ulcers on ND and QI. So we started calling around and saying, hey, how are you having 0 every month? And that's when the measurements became important. Because what we were hearing is we don't have 0. That's just when we did skin rounds this month. So we talked to our nurses and we said, so tell me, what are we gonna do about our happy problem? Now, what do you guys think our nurses said? What happy problem? We don't have a happy problem. So we had to get the numbers to them. And so we started off with that lovely chart kind of towards the end where you see the 2012. And we went in and we started talking to them about how far above national benchmark we were. We weren't taking as good a care of our patients as we thought we were. As we continued down our journey, you'll see that we went down to near 0, and there were times we were 0. I was talking to Maria, she's my wound care nurse, at lunch today and told her that there's national benchmarks and then there's the Maria benchmark. And a Maria benchmark is 0. She doesn't want any of our patients to have pressure ulcers ever. And so that's a testimony to the culture that we actually created at our hospital, which is now a culture of prevention. And we're gonna go over that a little bit. So what was our problem? There were barriers and reactions. So let's talk a little bit about that. There was a wall in front of us, right? Our nurses were telling us we didn't have a problem with pressure ulcers. We're doing everything we can. You guys have probably heard that before, right? We're doing everything we can. Or you don't understand, our unit has very sick patients and there's nothing we can do to prevent pressure ulcers. So we were hearing those too. And so it felt like we were trying to look over the wall and think of things to do, and they were kicking the ladders out from underneath us. Then, of course, they were picking up problems along their way, right? Well, I can't give my patient what they need because we don't have enough pillows in this hospital. When I turn them, they just fall back over because I can't put anything behind their back. Or I can't do this because, you know, our chairs are broken. We had some recliner chairs that weren't reclining properly. What would you guys do in that case? Let somebody know and get them fixed, right? Well, we had some very innovative PCTs that thought if they turned trash cans upside down, they could prop their patients' feet on those. So what were we seeing? Pressure ulcers, right, to those heels. Lovely. So they were helping create some problems and carrying that weight around themselves. Then we would be going down the road and we would slam into a wall. We would find out we didn't have the supplies we need or what have you, and we're going to talk about those things in a little bit. And then sometimes we would just like hit that wall and try to go right up and over it, but we didn't have enough momentum. So let's talk a little bit here about what we started. So when we first started looking at this, we said we've got to identify what our problem is. You can't fix a problem if you don't know what's going on. So of course, being the good quality people we are, we did a fishbone diagram. So we went around, we actually talked to nurses. I think between Maria, myself, and our CNO, we probably talked to every single nurse at our hospital and said, what's the problem? And these are the areas that we came up with, okay? We had a unique patient population. Okay, if you've ever been to the heart hospital, we're very proud of our patient population. Nobody else has our patient population. We think we're awesome, okay? Well, they have lengthy OR times. And we'll talk about that in a little bit, but over 3 hours is a good percentage of our patients. They're on those tables for a long time. Our patients come in with multiple comorbidities. They don't just bring their heart with them, their whole body comes in. I was laughing when was it Teresa that said that patient's mother thought they were gonna take the heart out? It's not how our patients show up, right? They're hemodynamically unstable. We hear that a lot. I can't turn my patient. They're hemodynamically unstable. They have poor perfusion. They have PVD. And then the cardiac universal bed model. You know, I don't have a PCT in my room today because I have the ECMO patient, so how am I supposed to turn this patient? Then we had knowledge deficit. We actually were asking them questions. Braden scale knowledge. They were clicking the boxes in the electronic medical record, but when we asked the nurses, what's the Braden scale? They were like, I don't know, it's on my assessment. So, yeah. There was disbelief that we had a problem. They did not believe us. We actually had to take graphs around and show them. We found there was improper staging of pressure ulcers. They were marking things as 3s that were really 2s, and so they really didn't know how to stage. We had a lack of knowledge of the function of our beds. The nurses did not realize that there are markers on the side of the beds that tell you where you should be positioning your patient's hips for maximum, I want to say softage, but that's not the word, cushion. And then our Skin Champion team and Wound Consult came out of this knowledge deficit as well. Then a lack of collaboration. There was a big resistance to change. Okay, remember how I said to you, our nurses think they're awesome? And when nurses believe that they're awesome, it's very hard to get them to change, especially when they are really great nurses. So we had a lot of resistance to change. We had some physicians that thought it was a nursing problem. We had nurses that said it was a patient problem. So we had to overcome that change. A lack of nutrition consults. That was only being spurned when they would come in if they scored low on their nutrition screenings originally, but you know, now once we've taken them to surgery and we've messed with their heart, we have a whole different nutritional standpoint. We had an expedited admission process, so some of our patients come in and go through an expedited process. They may not get staged appropriately if they have a present on admission, or they might not get their skin looked at all. So we found out our day surgery nurses were not looking, they didn't want to embarrass the patient. So they weren't looking in all the places that they could have one present on admission. They didn't understand the roles between physical therapy and an RN wound care nurse. So at our hospital, we have both. Our physical therapy department does some advanced wound care for our patients. So they do the wound vacs and things like that. And then our RN wound care nurse takes care of stage 2 and below. And then we had a problem with interdisciplinary communication. You know, we had doctors that go, what do you mean my patient has a pressure ulcer? Never heard that before. Then we had supplies. We had a shortage of bed modules. So we have low air loss mattresses, but you know, those require a module to actually blow the air through them. And we found out that we had bought these lovely beds with low air loss mattresses, but didn't buy the modules to go with them. And we were renting modules, so we worked through a process to get those bed modules. And then I have to put a disclaimer here, Methylex. Lowell and Nikki did not pay me to say Methylex. It just happens to be what we use. You guys may have another type of dressing. but they didn't even realize that we had the sacral dressings available and we're not using them. We did have a lack of pillows. I have no idea where pillows disappear in the hospitals. If any of y'all figure that out, let us all know. And then the heel protecting boots. We just didn't have a good PAR level of those. Inadequate PAR levels. So looking with supply chain, we're putting in one, we take out one, it's gonna be the next day before they put something in. And then a lack of waffle cushions to put on the chairs and some of the beds. Then we had resources. At the time we started looking at this, we did not have our certified wound care nurse. I'll talk a little bit about how I managed to get that. PT at the time was doing all wound care and therapy, but they are too busy to actually get to those patients for prevention. They only react, okay? We didn't have good informatics intelligence, meaning our EHR wasn't very friendly in letting us know what was going on with the patients, and we worked through some of that. The weekends are problematic for us. How many of you guys have heard of the TDA program at Baylor, where they just work the weekends? And so, unfortunately, there's not a lot of resources and people there on the weekends, and so we saw an uptake in a lot of things over the weekends, including our happies or happy's. And then confusion on supplies. They didn't know what supplies to use when. They just did whatever they were doing because they thought it was good. And then, of course, our patient recovery process. So most of our patients are having some sort of cardiovascular surgery, and so as they come out of surgery, they have a lot of issues. So hemodynamic instability, the nurses didn't want to turn them, saying they're too sick to turn. If I turn them, their blood pressure is going to drop, and this or that or the other. Their nutritional statuses post-op. Because remember I told you we got them before surgery, but now it's changing, right? You've got a ventilator in, it's a little bit different than when you walked in off the street. Restrictions on repositioning, we still occasionally will run into this, but at the time we had doctors that were like, okay, Alaina's telling you to turn your patient, I'm just gonna write an order that says you can't, and that'll solve that. So we had to work with our physicians and tell them no. Patient's fear of moving. Any of you had heart surgery? You get that chest broke open, and they're scared to move. They think they're gonna break their chest. And so getting the patients to understand that they needed to move. And then we had some cultural considerations. So the first thing that we learned was that in order to come together and work stronger as a team, we had to think differently. And so this is a great quote from Henry Ford. It says, coming together is a beginning, but keeping together is progress, and staying together is success. So how are we going to address this and break through those barriers without letting it stop? So traditionally at our hospital, you get a task force, right? We have a problem, let's put a task force together. You're gonna now be on the happy committee, okay? Well, what's that mean? We're gonna look at a problem, we're gonna fix that problem, then we're gonna disband this task force and we're gonna move on to the next problem. What kind of culture does that create? It creates a culture of what I call the flavor of the month. Okay, oh, we're done with that. We've moved on to Cata. We've moved on to Class B. We did not want this to happen here. We wanted people to understand this is how we treat our patients every single day. So we needed to create something that was going to be sustainable. So what we're going to talk about for the rest of the time is how we said no and took down these walls. So we're going to talk about the team that we put together, the education that came with it and still continues to this day, how we changed communication, and our culture. So let's talk a little bit about our team. We put together a multidisciplinary team. First, we got a physician liaison. If you remember, I said that I was telling nurses to turn patients, even if it was just a little bit, to get them off those bony prominences, and our physicians were writing orders saying, don't do that. So we got a physician liaison for that and to help us oversee our program. His name's Dr. David Besteros, and he is fabulous. He runs our wound care clinic for us out in Plano. Then, well, we needed a nurse. We needed an expert. So the CNO gave me permission to try to justify hiring a certified wound care nurse. We started off with bringing her in part-time and having her do our part-time clinic, and quickly realized this was a full-time job. So I got the lovely job of going to our CFO and convincing our CFO that her salary was worth the amount of money that we could save by preventing HAPU. And I'm happy to say that she's sitting right over there and that I have now had her for 5 years, and been able to keep that going because it's fabulous. Our cardiac universal bed units, we required that we have a representative from every unit join our team because it is the entire hospital. It wasn't optional. Our nurse managers, so at first we needed our nurse managers on the team. Now they're only brought in when there's a problem on their unit because they have their unit representatives. But we needed to change that culture, and some of that culture needed to start with the nurse managers. Because we also had the problem of the nurse managers saying, but we can't do this, we can't do that, we don't have that. Back to the chairs. It's gonna be really expensive to get brand new chairs. Well, yes, but it's more expensive to have a HAPU, right? Education, so we brought educators in at first. Now Maria actually does all the education herself on pressure ulcer prevention across the hospital with her team. Our OR, we needed our OR representatives there. They didn't want to come at first. They said, we don't do anything in the OR to prevent pressure ulcers. That happens on the floor. And so we convinced them to come in. We're going to talk a little bit about that because we attacked them first. Our emergency department, we heard the same thing from our ED nurses. Oh, we don't keep them long enough. Well, those very thin stretchers, and you're there 3 or 4 hours, can start a nice pressure ulcer brewing. Our PACU, physical therapy and OT, and then of course we needed nutrition services there. Okay. So the first thing that we started doing was looking at education, and then we moved on to our OR. So the first thing that I did, of course, was add our certified wound care nurse to guide our prevention efforts. So I didn't hire her to go out and treat all of our pressure ulcers. I hired her to help us figure out how we were going to prevent pressure ulcers. Well, she went and sat through nursing orientation and said, you guys are given a little bit of information, nursing orientation, that's great, but it's not enough. So she developed a nursing orientation program that's now 2.5 hours long, and they have to go through many steps of understanding how to prevent pressure ulcers, not treat them necessarily, okay? We had to train our skin champions, so that's what we started calling our program at first, was the Skin Champion program, and they needed training. So we brought in some ladies from a hospital up in Ohio that had started a similar program, and we had them trained. Then I sent the entire Skin Champion team to an organization that was doing a workshop, hands-on skin, wound care, that sort of thing. And they all got trained. And we also had them sign a commitment. So they have to sign a commitment that they're gonna attend so many meetings, that they're gonna help with skin rounds. At the time, we started doing skin rounds weekly because we wanted to know what was going on an ongoing basis. And then if they fulfilled all their requirements, we paid them a bonus each year. And it wasn't much, a couple $100, but they had to fulfill all those requirements. We actually only ended up paying 2 of them because the others missed meetings or they didn't participate in rounds as frequently as we wanted to. And so it was a good message to them when they saw these other 2 get some money that they needed to participate. We started staff quarterly educational events. And so these are just a few, and we're gonna go over a couple of these in a little while so you can see them a little better. But we had brownies for Braden. We wanted to get the Braden scores out there. What does the Braden really do? And so Maria actually cooked brownies at her house, brought them in, and would trade information from the nurse about the Braden scale for a brownie. Now, when you take brownies on a nursing unit, what do you think happens? They come running, what's going on? And she's like, oh, now that you're all here, we talked to you about the Braden score, and if you answer a question, you get a brownie. That seemed to work, so we kept giving them food. They still get food all the time. We didn't ask the expert event. They said they didn't know what all we had, so we brought in all of our vendors, set them up in a room, and we had them go around and learn about all of our products straight from the vendors. We had a stage fair roadshow. There's a nice little carousel that we have, and they spin it, and then they answer a question, and they get a chocolate. And again, they love the food. And then we did one called Recipe for Disasters and Ingredients for Successes. And my favorite one's not on here. We did do a nutritional supplement tasting. So it was kind of like a wine tasting, but it was with supplements. And of course they run over because they thought it was their food. And we're like, yeah, you have to drink this first. Okay. Then we thought, how are we going to get this out to everybody? How's everybody going to be able to contact Maria, contact the Skin Champions, know what we're doing? So we came up now with, did we want to really be the Skin Champions? What would be something better? Because Skin Champions doesn't make a great phone number, and we knew we wanted to have a hotline, but that's way too long. So they came up with the Pressure Ulcer Prevention Team. And you guys may have heard, other people have stolen this name from us now. But Pressure Ulcer Prevention, and they call themselves the Pups now. And they actually have little mascots. They're little puppy dogs. And so we have the 4 pup line. So that's all anybody has to remember. I can get a hold of a Skin Champion by dialing 4 pup. That number's up there if you ever want to randomly call us. And then, of course, you know, what am I going to do in the middle of the night? So we got an email, dedicated email address, and that is also 4pup@baylorhealth.edu. And that goes to a shared email that several of us have access to and can respond to. And then monthly, they get the Pup Date newsletter, which is their updates every month. And those, I'll show you a sample of one of those in a little while, but those are meant to provide a little bit of education on whatever we've seen happening that month. And they're always really cute. So if you guys remember the whole deflate gate that happened at the Super Bowl, well, we had Don't Be a Victim to Deflate Gate because our waffle mattresses weren't getting blown up quite right. They were kind of deflated. And so our nurses took that because they were interested. What's this deflate gate stuff? And then, of course, our physician liaison and wound care nurse make daily rounds now. So we started with our OR. So let's go back and talk a little bit about our unique patient population. We have cardio surgery patients. We did a literature review. That's my answer to everything. Let's do a literature review and see what's out there. And we found that cardiac surgery patients are at one of the highest risk for pressure ulcer development compared to non-cardiac surgery patients. Makes sense to everybody in here? You know, they're usually on a ventilator. They don't want to move around as much. We're a little afraid to move them with their hemodynamics. So they're one of the most at-risk patient populations. We also know that HAPUs have long-reaching effects on patients and caregivers and our bottom line. We're a for-profit hospital. So those dollars speak louder to us than I think when I ever worked for any of the nonprofits that I've worked for. How are we going to save those dollars? So we had lengthy OR times. This graph is showing you the percent of our procedures at our hospital that lasted a variety of minutes. And that tall line that you're seeing there actually comes to 44.1% of our OR times that are over 3 hours. So almost half of our patients are laying on those tables for over 3 hours. And if you know anything about cardiac surgery, one of the things that we do is drop that body temperature, right, which puts them at an increased risk, and then we've got them on a hard surface. So we really needed to work with our OR. Our next lowest is between, that's 300 minutes that you'll see there, and then 400 minutes, 500 minutes, and then we've had patients on the table up to 600 minutes. So we have some 10 and 12-hour surgeries that happen at times. Also, our patients have multiple comorbidities. Most of our patients, when they come in for their heart disease, they've got diabetes. They've got a ton of other things going on with them. They're hemodynamically unstable when we get them out of the OR. They're cold, their blood pressures are low, their heart rates are low, so they're a little unstable for us. And then we have a good percentage of patients that have central and peripheral arterial perfusion disorders. So again, looking at the research, we saw what are the greatest risk factors here? Well, being over 62 years of age. So most of our patients who are having cardiac surgery fall into that. They're over 62 years of age. A serum albumin less than 3.5. An ASA score of less than 3 or 4, and that's for anesthesia. Surgery hours greater than 3. Impaired mobility prior to surgery. Some of our rather large patients, our obese patients and morbidly obese patients, have some impaired mobility. Smoking history. Have they smoked? We require that they haven't smoked in a year before they have surgery. That's not always feasible, but even if it's been a year, there still can be that history there that's impacting them. And then we also look at their prealbumin. Additional risk factors that impacted us were critically ill patients, patients with diabetes or peripheral vascular disease, and we have patients that have both. Thin body types. These are our little old ladies with their little thin body types. Low Braden scores. Men, this one was interesting. Men who experience a 1.8 Celsius drop in their body temperature. And what did I say we do during cardiac surgery? We cool them down, okay? The positioning on the OR table. And then, of course, what are their hemodynamics during the procedure? How many of you guys know what your patient's doing during their OR procedure? Not very many. Okay. So we needed to maintain skin integrity in the OR. So we started meeting with our OR nurses and finding out what's going on. We let them know, hey, close to 42% of your HAPIs, they occur in surgery patients, okay? What's the effects on the patients? They can have an increased length of stay when they have a HAPI, right? They're not gonna go home right away. What the literature shows us is that it can be up to 3 to 5 days longer. There's an increased cost to the patient and the healthcare system. And then some of the predispositions to other complications such as osteomyelitis from that bone involvement, sepsis, and then squamous cell cancer. So some of the problems we identified in our OR were heel and sacral HAPIs. Our OR surfaces, what was the thickness of the mattresses? We actually went in and measured mattresses and got our OR to buy some mattresses that were a little bit thicker. Were they putting on the sacral dressings? And so we worked very diligently with both our day surgery and our OR to make sure that those got on before the patient was on the bed. Offloading and repositioning. I actually sent my wound care nurse to the OR one day to just watch how they positioned patients and whether or not they were offloading. So they were not offloading heels, for example, because they have to prep the legs during surgery. So they didn't think they could offload the heels. So they started putting a gel roll underneath the sheets, prepping the legs and then laying them on the gel rolls. We saw a decrease in our heel pressure ulcers after that. We talked to them about skin assessments and found out that our preoperative nurses, they weren't looking at the skin. They were asking the patients, but they weren't looking. And we're like, you have to look. And so we taught them how to ask the patient, I want to make sure that we provide you really good care, so I need to do a thorough skin assessment on you. Then intraoperative, our nurses in the OR were also not looking at the skin. They bring them in, they move them over, they're doing all their various activities, and then they go over and they prep, and they never looked at the skin. And so we asked them to also start doing a quick skin assessment. So the first thing they do is they roll them up, they look at the backside, they put them down. Once the patient's asleep, they pull that gown away, they do a quick skin assessment. And then post-operatively, we asked our PACU nurses and our nurses out on the floor that receive the patients immediate post-op to start doing an immediate skin assessment to see if we had any red areas coming out from the OR. And then, of course, communication between the units. We started requiring that those areas also, in their handoffs, report, I positioned, I used gel pads, I'm seeing some redness on the shoulders. So what did we do to say no? This is our first cycle of interventions that we went through. So first we identify the problem, and we needed to get leadership support. In order to hire people and get a skin champion team that we were paying a bonus to, we needed support, all the way from our hospital president, our CNO, our CFO, to our physicians. So that was one of the first things we did, was rally that support and really letting the physicians know how that impacted them and their patients later. One of the best ways that we did that, we had a patient who was actually what people call a walkie-talkie, right? Comes in, they can essentially take care of themselves. He was having some pain in his sacral area. Never really mentioned it to anybody, didn't think it was any big deal. Went home, went to his doctor a few days later, and lo and behold, he had a hospital-acquired pressure injury on his sacrum. He went through months of treatments for that. We brought him back to our hospital, and we had him talk to our staff nurse council and our physicians and tell his story about the pain that he's gone through, the cost of his medical expenses, and why he never spoke up when he was in our hospital. He thought our nurses were great, and he didn't want to hurt their feelings. Woke everybody up. And we sought out resources. What resources do we need? We initiated our Skin Champion team, so our PUP team. Then we went around and we identified their educational needs, educated those experts that we were going to build. We started bringing in our ancillary departments, remember, nutrition, physical therapy, everybody. We initiated clinical support in the form of our wound care nurse and our hotlines. And then we said, well, we seem to have left some people off. So we started adding to our team. We have advanced practice nurses and physician's assistants in our hospital we had not talked to. So we added them to our team. We found out there were different levels of nutrition support, so we started adding the various people in that. Nursing informatics, we couldn't get information from the medical record. Then we expanded our nursing knowledge at the Ask the Expert, and we started identifying our at-risk patients prior to procedures. So we started receiving, our team receives a report, the CPM reports are from our OR scheduling manager. And so we receive a report the day prior that lets us know what patients are having what procedures and estimated procedure time. So if they're going to be longer than 3 hours, we're already in there having conversations with them. Then the next thing we did was to increase our efforts. So we increased the role of our certified wound care nurse. I went back to our CFO and rallied that I needed her full-time. We needed to improve collaboration with supply chain and our ancillary departments. We had tons of meetings with supply chain about getting in enough product for us. And then we took that to the system level. We have a system happy council now. And we really have worked with supply chain to make sure that all of our hospitals have the supplies that they need. And then we increased our staff educational events. We have education for our staff every month in the form of roadshows. They don't have to leave their departments. We go around with a little cart, and there's always chocolate on it, so they want to come see us. Okay. We obtained a map for 30 days. If any of you guys know about the MAP system that maps out pressures on beds. We did a trial for 30 days and found that we had some electrical interferences that time with those maps and a lot of our equipment in the ICU patients. But what we found, the staff thought was really critical, was that when we were using it in our lab, we have a bioskills lab, they could see when one of us would lay down where the pressures might be and understood better why they needed to move those patients off of that. So we now have one that we use for teaching. We launched our PupDate newsletter, and then we initiated a progressive mobility, that should say walking program, to get our patients up, even if they're still ventilated. They can get up if they're able to get up and walk. You take their ventilator with them. And then one of our skin champions did a Move to Improve campaign. And that is where the patients engaged in moving. So they get a turn clock in their room. It's got a little heart on every 2 hours, and they're to get up and move, change their position, move from the bed, whatever they need to do to move. It's kind of like your watch, you know, that tells you now to stand. So we needed to change our culture. So we had to move from a culture of proactive prevention is where we're at now. We were in reactive, right? We were reacting and treating. So into a proactive prevention culture. And now we want to move to a culture of innovative interprofessional initiatives. Okay. So that's where we're headed. We need to continue our rounding and collaboration, expand our education events and opportunities. We keep recruiting new skin champions, providing support to them at the bedside, and including patient and family in the process. So what's being proactive? Well, we talked about, we did the Braden score, the PUP dates. We're going to go a little bit through some of these for you right quick. So this is the Braden scale. If you're not familiar with it, it measures these 6 areas, helps us identify who's most at risk. Sensory perception, moisture activity. It gets scored out. Anybody that scores out at moderate, high, or very high risk is then seen by our wound care nurse or our skin champions every day. These are some of the interventions. This is a copy of the PUP date. As you can see, this went over the Braden scale for them. This is our apples that we use during orientation to teach how to understand the staging. You guys see, you've got your stages there. We get to eat apples every day. This is our Halloween one from last year. Don't be afraid to peek under the Mepilex. So making sure that people were still checking. Okay, we got our patients and families involved. I'm gonna go through these quick because we've only got a few minutes. Then we started helping others say no. So we started going out and talking, working with our system. These are some of our interventions that we started doing, identifying the at-risk patients, making sure we had medical records, doing those skin assessments, putting on the Mepilex dressings and such. Interoperative, again, we looked at support surfaces, positioning devices, getting those heels off. Postoperative, we taught the nurses to continue to monitor those areas, early ambulation or low air loss. Immediately post-op, we look at all these risk factors, and we help the nurses to kind of tally up how many risk factors their patients have, their Braden score, and determine whether or not they need to be seen by a skin champion. These are some of the places that Maria and I have shared our journey. So our challenge to you guys today is, how are you going to say no to happy? You're not saying no? Did anybody get sappy? No? No, just so she got sappy over here. She's got a little sappy. Okay, we have like 2 minutes if anybody has questions.
Do you consider preventability when you're looking at your happies? And my next question would be, do you involve physicians in any way, or is this all nurse-driven?
No. Yes. It's not all nurse-driven. So it's a multidisciplinary. So we're going to pull in the nurse, we're going to pull in the physician, we're going to pull in the OR team, whoever we have to do. And we do look at prevention. So if we develop a happy, if we have a patient that gets one, when we go back through, we look to see what interventions were in place and what were not. Okay? She's like trying to pull me off. So if you guys have questions later, I'll be over there.
The hope is coming out.
Thanks. You're welcome.